This is case L3CT A68. The case history is that of a 79-year-old woman who has known moderate aortic stenosis established by prior echocardiography, who now has progressive shortness of breath and dyspnea on effort. We begin with general inspection of the study. Here we are at the base of the heart, at the base of the aorta, pulmonary artery. The aorta may be slightly elevated, enlarged. We can check this very quickly by pretending to be an M-mode echocardiogram and taking a check through this area. 33 millimeters is considered to be within the range of normal. Moving caudad, you can see that the left atrial appendage appears to be intact. Left atrium may again be possibly mildly dilated. We can recheck this looking at a view such as a M-mode echocardiogram, getting an upper limit normal of about 38, 39. So upper limits of normal to possibly mildly dilated left atrium. You can also see that there is some calcification of the aortic valve. In this area, it appears to be a tri-leaflet aortic valve, however. And the thoracic aorta appears to be generally normal, although there may be some mild plaque in the walls of the vessel. This is the review of the left ventricular function and the left ventricular valvular dynamics. This is a horizontal long axis view, and we can start this in motion. Appears to be quite normal to hyperdynamic function in the septal wall, apex, and lateral wall. We move then to the vertical long axis view, again demonstrating excellent function in the anterior wall, apex, and inferior wall. Finally, we can return to a short axis view, demonstrating again excellent function, normal left ventricular chamber size, septal wall, anterior wall, lateral wall, and inferior wall. We can take a better look at the mitral valve leaflets. You can see here that the anterior valve leaflet appears to be thickened. There may or may not be some thickening of the posterior mitral valve leaflet. However, they open normally. Here's a view of the dynamics of the aortic valve, again reconfirming that this is a tri-leaflet aortic valve. If we put this in motion, we can see, however, that there clearly is some restriction with some evidence of the aortic stenosis noted on a prior echocardiogram. One can planimeter this area and get a reasonably valid measurement. However, most people consider echocardiography to still remain the reference standard for performing aortic valve assessments. Let's now commence looking at the coronary arteries. You can see that the left main artery appears to be normal at its origin and throughout most of its course. At the distal end of the left main, or near the ostium leading into the left anterior descending, there is some moderate eccentric non-obstructive plaque in this region. Next, we look at the left anterior descending coronary artery. Again, there is some moderate non-obstructive disease at its ostium. This is a very large diagonal, probably the dominant vessel coming off very quickly, and there is some complex or mixed plaque in this region that appears to be significantly obstructive at the ostium of the diagonal. As we proceed down this diagonal vessel, we can see other areas, in particular in this segment here. This does not appear to be obstructive, but this has features of ulcerated or dissected plaque. Further down in the vessel, there is diffuse non-obstructive disease. Returning back to the left anterior descending artery, which itself is relatively small, there may be some obstructive disease at the origin of the mid-left anterior descending. However, as we proceed down further in the mid-left anterior descending, you can see that there is non-calcified obstructive disease in this region. Following the remainder of the LAD down, there is only little or no disease in the distal segments. We now begin looking at the left circumflex artery. Comes off right at this juncture. There is probably a small ramus intermedius branch, and then a small proximal OM1 and probably an OM2. The vessel is non-dominant and otherwise normal. We now begin looking at the right coronary artery. The ostium appears to be normal. There is some mild plaque in the proximal segment as we proceed down into the proximal near the mid portion of the vessel. There is some mixed plaque representing non-calcified and calcified plaque that does not appear to be obstructive. The remainder of the right coronary, however, appears to be generally normal down to the distal segment. As we get near the origin of the posterior lateral branch, in these areas there is some mild plaque at that origin, and the posterior descending artery here is quite large and otherwise normal. So in summary, we have a 79-year-old woman who has known moderate aortic stenosis, and we have reconfirmed that with the CTA. She's had progressive shortness of breath and dyspnea on effort, and she clearly has obstructive disease and a large dominant first diagonal as well as obstructive disease in the small mid left anterior descending coronary artery. There is no clear disease in the circumflex, and there is moderate but non-obstructive disease noted in the right coronary artery.